Yeah, we were supposed to end this at noon, but we have a couple more items. I'll try and go through these rather quickly. First of all, the purpose of this, everyone is supposed to have a compliance plan nowadays. And sometimes it gets to be difficult. Okay, what do we need to be looking at with our compliance plan? So this is an idea that you can go to the OIG, the HHS OIG website, and look for the OIG work plan, and they will describe for you what they are looking at when they go into hospitals and do audits and other sorts of stuff. They get that information from other parts of the federal government. So they, at least it tells you what the federal government thinks is important and may be going on in regards to improper billing and other sorts of stuff. And what I have done here is I have taken out the portions that belong to hospitals. I feel a little bit like this slide. I have had so many Zoom meetings and stuff, sometimes you're not sure if you're being heard or seen. So sometimes you have to be a mime when you talk to people. Let's see, sleep testing procedures. I personally have been diagnosed with sleep apnea. I cannot use one of the various and sundry masks that they have become available. And I have gone back a couple times to physicians. Well, we need to do another sleep apnea test. Well, the OIG is taking a position. Well, if you've been diagnosed with sleep apnea once, you probably have sleep apnea today. There's not necessarily to retest and retest. They're looking at short stay claims, outpatient issues, issues around the 2 midnight things that they have been looking at in the past. They're going to be looking at that issue again. And as you know, there are outlier payments for outpatient claims that go over the standard norm. They're looking at some of those to see if being paid too much for those types of claims. Bariatric procedures, they've looked at, and there are certain things that has to be in the medical record before they will pay for a bariatric surgical procedure, and those are listed here. They're looking at CERT issues around billing errors in the medical records and in the bills that hospitals send in. This is one they've been looking at for quite a long time. Quite often medical devices have to be replaced. And the provider of those medical devices will provide those devices to the hospital or to the ambulatory surgery center at no cost when they're being replaced, at least in some situations. Well, if that occurs, the hospital or the surgery center is not supposed to bill for those replaced surgical devices. Well, apparently in some situations they are billing for those. I mentioned I have sleep apnea. There's always something new. A non-invasive home ventilator is something new that has come along. I think probably quite a bit of these are probably going to be used for people who are recovering from COVID, because they are almost like a hospital ventilator except at home, and can be used for people who are having difficulty breathing. What they're afraid is people who, like me, have sleep apnea, maybe they will be prescribed these more expensive ventilators as they go along. As again, I think quite a few people recovering from COVID probably will be using these kinds of ventilators. Hospice, they're always looking at hospice. Hospice is sometimes sending people for care in relation to the reason they're in hospice. They will pay for care for reasons that someone is not referred to a hospice program. For instance, somebody has lung cancer, but they develop a heart condition along with the lung cancer and want to be treated for that. Medicare would pay for that. let's see, they're looking at transfers. They're looking at transfers between hospitals and nursing homes, between hospitals and home health agencies, between hospitals and anyone else they could be referred to. A DRG payment is when a patient, a Medicare patient, is referred to home. And what they've discovered is a lot of people are being, the billing indicates that the patient has been transferred or discharged to home, but that is not the case. They've been transferred or discharged to another provider, and the payment is less or different for a hospital if they are not transferred somewhere besides to home. Looking at quite a bit of those. Critical care, E&M care. There's going to be a lot of this because there's so many people having to have critical care with COVID. They're going to be looking at what the record, again, critical care is time-based. You put in the record how long it took you, particularly, for the physicians, how long they spent with the patients. So there's going to be a lot of evaluations and examinations of documentation for critical care, I'm afraid, for COVID patients in hospitals. Again, this issue about being transferred at the end of care in a acute care hospital to, quote, to home, when in fact the patient is transferred to somewhere else, another provider, such as a nursing home or somewhere else. Again, the issues around transfers, home health. Home health, if Chris mentioned that home health was allowed to use telemedicine, telehealth services, at least for a while, rather than people having to go into someone's home. They're going to be looking at all kinds of telemedicine and telehealth services, because unfortunately, that's one of those things that's easily mismanaged, or intentionally fraudulent activity can occur, and it's without some kind of oversight, people be paid for services they didn't provide. People, home health, again, they have to be homebound and they have to require skilled nursing services to qualify for home health. Facet joint procedures, these are pain management procedures for back pain. On the one hand, they tell providers to quit giving so many opioids. I think people are, but they have to have something in lieu of opioid when somebody is in severe pain. One of these is these injections that can be administered, particularly for back pain. So now they're saying those are being misused. So what do people do experiencing severe back pain? It becomes very, very difficult for patients to get care for severe back pain because of restrictions on opioid use and now on these other. I mentioned sleep apnea. They're looking at those. Urine drug testing. John and I have seen a lot around this. Substance abuse is, unfortunately, a lot more people have committed suicide, intentionally maybe or unintentionally, with substance abuse issues. And treatment for substance abuse requires examination and evaluation to determine if someone is using drugs. And the easiest way to do that is with a urine test. So again, it's one of those things that can be overused. So they're going to be looking at urine testing, and the hospitals do urine testing. Hospice caps are in place now. They're going to be looking at those. Again, laboratory services, urine testing, and all kinds of other testing they're going to be looking at. Discharges from a rehab hospital to home health. They're looking at that issue. Some transfers from a rehab to somewhere else is like an acute care hospital transfer to another facility. The acute care hospital is supposed to be paid less than if they had discharged them home. So they're going to be looking around issues about discharges from rehab facilities to home health agencies, more transfers. They're going to be looking at situations where two physicians are involved in a surgical procedure and how the billing occurs. When this occurs, there's a particular code that's supposed to be used by the physicians, and they're going to look to see if in fact that's occurring. The DRG window, we've talked about that every year that I've been talking to you all about this, and that's the issue of billing and getting paid for services prior to admission of a Medicare patient for inpatient care. What can be billed separately, what can't. Advanced care planning services, they will pay for that now. Someone decides they want that DNAR order I mentioned earlier today. Physicians now can be paid for advising and talking to and working with the patient to do that. But unfortunately, again, certain documentation has to be in the record if you're going to build it. Telehealth expansion, mentioned that a while ago. They're going to be looking at that every which way. Bad debt, that's something that y'all all experience, unfortunately, constantly. And I'm sure that it hasn't gotten better, it's gotten worse. So they're going to come in and look and see if you are pursuing your bad debt as you're supposed to in order to claim some reimbursement from Medicare and Medicaid for those bad debt. Chris mentioned swing bed services in his presentation. They're going to be coming in and looking at swing bed billing and seeing if swing beds are being overused. I mean, I don't know what you do if you don't have anywhere you can send the patient except to a swing bed, what you're supposed to do. But at any rate, they're going to be coming in and looking at that. Chris and John both mentioned provider relief funds. Y'all going to have so many auditors, and you're liable to have one or two auditors at the same time come and looking at funds and their uses, because they're going to come from different places. It could be OIG, it could be all kinds of individuals. Just be prepared for audits. I mentioned the two midnight rule. The OIG has said they were not going to look at that again, because if y'all recall, that there's been some lots of discussion about enforcement of what is an inpatient, what is an outpatient. And they tried to use this two midnight rule. Well, the OIG is letting everybody know by putting in their website, they're going to be looking at it again. Issues around outpatient versus inpatient care. Let's see. Someone is an inpatient and they receive care as an outpatient somewhere else. Someone is at a hospital and they go for an MRI to another facility. The hospital is supposed to receive payment from Medicare and make payment to that outpatient facility for that care. Again, another mention of telehealth. Something the older I get, the more I get to experience our healthcare system. I was a sun worshiper, so I go and see a dermatologist every 6 months, and she takes something off of me. And she also examines me quite closely all over before she probably finds something to take off of me. Well, billing by a dermatologist when they remove something, they're not supposed to bill for both the surgery and the examination as well. So that's kind of puts the dermatologist in a bit of a bind to me, because I certainly want my dermatologist to look to see if something else has cropped up since the last time I came in to see my dermatologist. Let's see. I was trying to get through some these things that you need to know. By the way, if you'll see the numbers down on the bottom, there's a lot more in our information that we provided to Jane and to Bethany than the ones I'm going through. So if you really want to look, this is a way you can go through without having to physically go and look at the OIG website at least today. Physician services when somebody is an inpatient. Physicians are supposed to bill differently for Medicare patients depending on where that patient is located. They get paid a little bit more when that patient is seen in the physician's office. And the idea being it takes more additional staff, all kinds of stuff to take care of a patient in the physician's office versus say a hospital. But evidently, at least in some occasions, physicians are billing or somebody is billing on the physician's behalf as if all of the patients they are seeing, wherever they are being billed as if the patient's being seen in the physician's office. They're going to look at emergency management, not emergency department services. And again, how many people have come through you all's emergency departments nowadays? I keep hearing over and over again, people come to your emergency department and stay for days and days and days because there's nowhere else to go for them. So what will these audits come up with? I do not know. Anyway, that is the end of my presentation, and thank you all for sticking with us through the end of this, those of you who did.
Just a few closing comments before we sign off. First of all, we'd really like to thank everyone for joining us, for sticking with us through the various technical difficulties. We hope it's been informative and helpful for each of you. Remember, the slides are available. If you don't have them, you can contact Bethany and she can get those to you. Also follow up with her with respect to any continuing education requirements. If you have any questions, our contact information is on that last slide, and I think most of us are in for the rest of the afternoon. So if you have anything particularly related to what we talked about today, we'd be glad to try and help you with that. Otherwise, I hope you have a great lunch and go enjoy the rest of your day. Thank you for joining us.